Dr. Cockshell, what types of conditions do you see in your e-consult request? This kind of goes along with what Maggie was sharing with us. I'm just curious what you're seeing.
Mm-hmm. I see a spectrum. I see lesions. I would say that's the minority, kind of like, what is this lesion? Is it cancer? Is it just seborrheic keratosis? Like, is it something benign? Can you confirm? And for those consults, it's really helpful to have the dermatoscopic images. Like, I can really confidently say what something is if I have those. And sometimes the images aren't quite as good. I can't give as good feedback on those, but I'd say the majority are rashes of some sort. Either it's a known rash like psoriasis or eczema that just hasn't been responding to treatment. And then I'll look at what medications have been tried. I'll look at the history that's provided. And I'll usually just offer recommendations on that. If it's very severe, I'll talk about biologics, and I'll say at some point this patient should probably see a dermatologist. So I do see a good number of those. And then sometimes I'll just see mystery rashes, like really unusual or uncommon things, or things that just have the provider stumped. I saw one, very recently that was bullous pemphigoid, which the provider didn't know what it was. It's very uncommon. For dermatologists, we see it frequently. And it's one of those things that's tested on the boards, and you see it and you know it immediately. So for that consult, I could just say, this is what this is. You don't have to do a biopsy. You don't have to do anything else. This is what this is, and this is how you treat it. I mean, those happen once in a while, but then there are those where I'm like, I'm not sure what this is. This patient needs a biopsy. And that kind of, ranges more into the complexity scale. But I would say it's probably like 70% rashes, 30% more skin cancer lesion, and then a little bit of acne. Sometimes I see some acne and just treatment recommendations for that.
Awesome. And it sounds like most of these, or do you feel most of these can be treated in the primary care setting?
I do. I think at least initially, especially if the provider has the capability to do a punch biopsy or a shave biopsy, can be treated in primary care, because I've had a handful of cases where the provider will reach out after the biopsy has been done with follow-up and say, this is what the biopsy showed. What do I do now? Mm-hmm. And I'm more than happy to work with the provider on those. And I feel like, because we're still dealing with the situation where the patient can't see a dermatologist for 8 months. So if they've had the biopsy and they've had the path results come back and the provider reaches back out to me, I can still manage that remotely. And, for sensitive area biopsies, yes, those patients they need to see a dermatologist. But as Maggie was saying, if you reach out to a dermatologist in the community, certainly this would be true for me, and ask to see someone, in a more expedited way, or a dermatologist has looked at this. I mean, I would try to get that patient in pretty quickly. So I think that setup kind of tends to work pretty well. But for the most part, I really do feel like I can help providers, especially if they're dealing with an access issue, do as much as I possibly can remotely with good photos and a good clinical history.